Entonces, siendo las 7 de la mañana, ¿comenzamos, doctor? Sí. Muchísimas gracias a todos por estar acá. Gracias, doctor Echeverry y el grupo de cardiología por darnos este espacio para esta importante eh, charla. Tengo el placer y el honor de presentar a Joao Cavalcante, al doctor Joao Cavalcante. Muchos títulos, todos increíbles. Yo creo que cualquiera que comenzó en resonancia cardíaca pues, y que ha leído tus artículos, que ha leído tus textos, pues se inspira por seguir continuando trabajando en resonancia cardíaca. Yo creo que Joao es uno de los mejores expositores latinoamericanos de la resonancia cardíaca y le debemos mucho. Yo creo que te debemos mucho y gracias por impulsar, inspirarnos a nosotros los que comenzamos a tomar este camino del uso de la resonancia cardíaca en la medicina cardiovascular. Entonces, sin más preámbulo, Joao, muchas gracias. The floor is yours. Lo puedes hacer en inglés, si quieres, no hay ningún problema. O en español,
Sí.
en portugués, sí, no creo que podamos.
Qué buenos días. Muchísimas gracias por este convite y para la oportunidad de estarmos juntos virtualmente a desarrollar un poco de los aspectos de que la resonancia de la imagen multimodalidad se te podría ayudar para los tratamientos, la diagnóstico y los tratamientos de los pacientes sufriendo de insuficiencia aórtica y tricúspide. Mira, mi español no es tan bueno, es un portuñol, digamos, pero yo no sé si, yo creo que se va a hacer mejor para cambiarnos para lo inglés algunas veces, ¿no?
Por
Pero yo
favor,
voy a
por
tentar,
favor. No, por favor,
hacer,
si quieres en inglés está bien. En inglés está
okay.
súper bien.
All right, so let's go to English then. If we look into the prevalence of valvular heart disease in the modern world, there are two important epidemiological studies. I will start with the ox valve. Just for the topic of aortic regurgitation, how common aortic regurgitation is. And typically when I give this talk, there is an audience response system that I ask, which one is more common, aortic stenosis or aortic regurgitation? I consider moderate and severe, and people typically say, well, aortic stenosis is a lot more common than aortic regurgitation. And that's currently what we see because those are the patients that come to the hospital we treat with TAVR, with aortic stenosis, and there have been more than 20 years into that development. But if we look into the community, patients 65 and years of age and older, you can see that the yellow circle here of aortic regurgitation is a lot more common than aortic stenosis. And in fact, the combination of aortic regurgitation and mitral regurgitation is even more common than that. Of course, sclerosis, it's when the valve starts to have some calcification, fibrosis. This is a lot more common. But needless to say, the top three are tricuspid, mitral, and aortic regurgitation. You could say, well, but this is a selected cohort from UK, England, 65 years of age. We did this exercise a couple of years ago here in a city, Minnesota, called New Ulm. Of course, Caucasian population. A decade later, 75 years or older, the incidence of significant valvular heart disease, moderate to severe, increased from 6.4 to 16, so it tripled. And the top three again are the same: TR, MR, AR, 7.2, blah, blah, blah. Aortic stenosis is 3 times less common than aortic regurgitation. So you could be asking yourself, where are these patients? Because we don't see them. They don't come to the hospital. And that indeed might be true. And the problem is that this diagnosis tends to be late. These patients tend to be suffering from AR for quite some time, and we have a problem in the diagnosis. For us to intervene into aortic regurgitation, you got to have the two S's: severe and symptomatic. Of course, you can intervene when it is asymptomatic, but then you're going to have to look at the ventricle. We're going to talk about that as a class 2A. But both European and American guidelines, and the European might be updated soon now in September for the ESC, they still ask us to define what it is severe aortic regurgitation. The problem is that making that diagnosis is not so simple. When you look into the guidelines, the first reaction you would have, it's probably, there are too many colors. There are too many arrows and boxes pointing to this and that direction. And the criteria that is called specific for severe AR is this multi-parametric. And multi-parametric for me is the more US to measure, the less you get it. Because not all the time you will be able to measure all of them. And when you can measure, then it does not tell you how it should be the hierarchy of these parameters, which one should be weighted more than the others. And sometimes you don't have concordance between these parameters. And by the way, where's the left ventricle here? There is nothing about the left ventricle, which is the ultimately end chamber that will be receiving this chronic aortic regurgitation and should be dilated by then. And the dilation best expressed with volumes, not linear dimensions, as we will talk about. So the guidelines are complex. The guidelines are too multifactorial. And at the end, they say, well, good quality echo is assumed. And if technically difficult, go for TE or CMR. In reality, we are not being able to measure. And that for us that read echocardiography, it is better to call the AR severity to indeterminate, meaning it could be severe, I'm not sure. Please get something else, than to call what it's not, than to undercall, because what we see traditionally is, oh, it's not severe. Are you sure? And that could be severe and the patient gets missed. This is applicable to both aortic regurgitation, tricuspid regurgitation, a lot of valvular regurgitation. So what do the guidelines say about AR? Using of MRI, it's restricted. They call it restricted to situation when the Doppler severity is equivocal or the quality is suboptimal, like we talked about, provides the confidence that AR is the cause of LV dilation. I'm not sure that I would have gone with that cause, because sometimes you might have cardiomyopathies. You might have another process going on that is causing LV dilation and decrease EF in the presence of moderate aortic regurgitation. That's not the cause, but is a contributor. But nonetheless, it provides accurate and reproducible assessments of the regurgitant volume fraction and as well as the LV volume morphology and function. So precision is what we're talking about. And for patients that have moderate aortic regurgitation, in our group here, a lot of our colleagues have been monitoring these patients longitudinally with aortic with cardiac MRI. So it can do a lot of things. This does not require sedation unless the patient is claustrophobic. This does not require general anesthesia for the TOE. You don't need to be NPO. You don't need to be fasting. And this could be a 30-minute exam. I'm going to focus obviously in the aortic severity and LV remodeling, but not to say that it can look at the valve, it can look at the morphology of the aorta, and can do all this quantification. Now, when we use cardiac MRI, it's important for us to also understand that the thresholds that the guidelines use for echocardiography should not be applied to cardiac MRI. And the reason for that is that cardiac MRI typically it measures completely different. And this is a study from Cleveland Clinic looking at the gradient between echo and MRI. When 4+ here considered severe by echo, you can see that the regurgitant fraction is not 50%, is around 34, 35, 36%. So it's mid-30s when you measure either at the SDJ. We tend to measure at the sinotubular junction. The further out you go, the lower you're going to get, and this tends to be more reproducible. And here I put together at least 950 patients. That's 1,000 patients by MRI. It's not a small study. Patients there are asymptomatic or minimally symptomatic, class 1, class 2. What is the threshold of aortic regurgitant fraction? And regurgitant fraction is the amount that regurgitates, the regurgitant volume, divided by the forward aortic flow. So how much of that regurgitant fraction associates with the progression of symptoms, associates with the need of SVR? And you can see that on average here, they're around this mid-30s, which is what we saw by the prior study to be severe. Yet the guidelines say that severe aortic regurgitation should be about 50% by regurgitant fraction. Well, that's by echo. And the reason that echo tends to be higher is because that LV stroke volume, which is the denominator, it tends to be underestimated. When you look at echo volumes by MRI volumes, we tend to be slightly lower by echo than MRI. So I, have been doing MRI for the last 15 years in this domain of, valvular disease, as well as other cardiomyopathies, etc. And I probably have counted into 2-3 hands patients that have presented with the regurgitant fraction by 50% or more. By the time they are into the 50%, the ventricle is beyond dilated. And that's a problem with us using the 50%. You can see here in this ROC curve, the 50% is extremely specific, but it's horribly sensitive, which means that everybody is going to be severe, but I missed a lot of patients that would have been severe just because I set the threshold very high. And that's not what we want to do as a screening test, as a confirmatory test. In fact, just to show another point, comparing echo versus MRI on this underestimation, when MRI calls severe by this regurgitant fraction of 35% and above, the echo AR severity was undercalling them to 33% of these patients. 1 in 3 patients will be undercalled. So confirm by MRI or TOE or TEE the severity when this is not clear when you're doing that. Now, moving to the asymptomatic patients, that's even a bigger group of patients. The problem also in the guidelines is that not only the severity that we talked about, but also how we're going to be adjudicating which ventricle is ready for intervention. And the problem is that we are using this linear dimension. So you have to have either an ejection fraction that is below 50 and a ventricle that is greater, the dilation is greater than 25 millimeters per meter square, linear. So where do these thresholds come from? It come from 1983. Some of us were already born, and maybe some of you might already be practicing cardiology. I was not there yet. But it was at the time of the cassette tapes of IBM XT, of Michael Jackson's Thriller album, great album. But it came from this cohort of a little over 70 patients published in Circulation, in which they saw that patients that had an end-systolic diameter greater than 50, and then index your body surface area typically of 2, then you got 25, they tended to be worse. But that's great back then. That's all you had. But nowadays, you have a multitude of ways to do that. And we're going to show that volumes are better. But when you look into these 3 cohorts, we're talking about almost 2,500 patients here. This is Cleveland Clinic, this is Mayo Clinic, this is Belgium. The threshold of asymptomatic patients that progress to death or progress to need for surgery or outcomes, heart failure, hospitalization, etc., it's not the 2.5 or 25. The inflection point, the risk starts to increase at 2.0. So if you're going to use linear dimensions, use not 25, but use 20. But volumes are better than linear dimensions. In fact, when they saw in this Belgium cohort here, class 1 indication is patient has severe symptomatic aortic regurgitation. When they intervened, post-operative survival was worse. It's better to intervene not when you have symptoms. Perhaps it's better to intervene when you have this class 1 or 2B, 2A or 2B, which is measuring by these thresholds. But it's better to intervene maybe when you have no triggers, when you just have severe AR. So this is going to be pushing us to reflect what the guidelines, and this is a work from our group looking at echo and MRI side by side, volumes by MRI. You could use volumes by echo as well. But volumes by MRI, typically the end systolic volume greater than 45 is the one that best discriminates. And you can see that 25, that the guidelines does not discriminate. And in addition to that, the aortic regurgitant fraction, we found this threshold of about 32. So regurgitant volumes, regurgitant fraction, and end systolic volumes is what we should be monitoring these patients with in 2025. What is the problem? By the time they present to surgery, they don't get treated. So that's the problem, is that we keep monitoring. Oh, they're not symptomatic. The ventricle is okay. We are missing the threshold, and then they're too well, now too sick. And so only 1 in 4 patients receive surgical AVR. So there's a massive undertreatment. This is looking at 2021. And you can see that obviously their mortality when they get surgery is still high, but even higher if they don't get anything. And this is not randomized according to ejection fraction, but those that get surgery in red have a better outcome than those that don't have. Can we do better? And that comes obviously the call for transcatheter valve interventions. And the Bottom line is that using the valves that were designed for aortic stenosis to be applied to aortic regurgitation does not work well, because these valves were designed to be anchoring into a calcified restricted valve. Patients with aortic regurgitation, the mechanism of aortic regurgitation is typically not related to calcification. Yes, sometimes you might have some mixed valve disease, but even then, it's mostly fibrotic, not calcified. And typically you have cusp prolapse, and that's why it becomes so difficult to make the diagnosis, because the jet is eccentric. So in this case, you need to have special devices. When you use TAVR valves that have been made for aortic stenosis, you typically have more insufficiency, paravalvular leak, residual ER, valve embolization, and sometimes you have to oversize by quite a lot. Align AR was a study that was completed and now presented and published, 180 patients to identify with severe symptomatic aortic regurgitation. It took more than 3 years to find these patients. And the most common reason was that the patient was symptomatic, the echo was done, and these patients were felt ultimately by the core lab to not have severe. Again, the difficulty in making the diagnosis. We took this challenge and we thought about, using, can we use the CT? Now, I don't have access to cardiac MRI, but can I have CT? And this is just showing AI for AI, so artificial intelligence for aortic insufficiency. How can we use our segmentation by CT in a functional dynamic CT, 4D CT, to really identify. This was a patient that was called to have normal ejection fraction with normal size ventricle. You can see that by CT you get completely reclassified. And diastolic volume is not 92, which would be the upper threshold, is 132. This patient has LV dysfunction. You can see a supercalcified right coronary artery, which causes this ischemic cardiomyopathy, inferior infraseptum RCA infarct. And then you can see in times that the aortic root dilates or the STJ dilates, you can have the central failure of coaptation, which is in this patient here. You can measure this anatomical regurgitant orifice area. And this AROA, typically above 0.35, it's been seen to be associated with severe aortic regurgitation. So obviously it requires a good CT acquisition. It requires a good temporal resolution, but that could be a substitute of MRI. And we are now presenting this data. We did the preliminary study at London Valves a couple of years ago. We have now taken those patients that were screen failed for Align AR, and we're presenting at the upcoming New York Valves, using CT or MRI to reclassify. This was a patient that the echo was done. You can see the regurgitation. There is mitral and aortic regurgitation, but ultimately the AROA and the regurgitant volume and everything was consistent with moderate aortic regurgitation. And then when the patient went to a CT, you can see that this anatomical regurgitant orifice area is 1 square centimeters. That's not moderate, that's severe aortic regurgitation. And the ventricle is severely dilated. And you can see here that there is the cusp prolapse of the right coronary cusp. This jet is going to be very eccentric, just like what we saw with the transthoracic echocardiogram, but here I cannot do the precise quantification. Patient got ultimately treated with a Jena valve, and this is a valve that has these 3 locators, 3 markers, so there is commissure alignment. We use TEE to align this valve properly, and when it's deployed, you can see great results. There's no paravalvular regurgitation, but this patient had already a right bundle branch block, actually developed a post-TAVR left bundle branch block, and ultimately with the cardiomyopathy received CRTP. This is the valve looking at with CT at the follow-up, which we typically do. This is the right coronary artery. You see a nice commissure alignment, and the left is coming right here as well. So we're with a very low mean gradient. So because there is no calcium, this valve can fully expand, and we typically see this mean gradients in the single digits. Now, pacemaker is still a problem. We are still looking at to identify perhaps is the design of the prosthesis. It has a saline skirt that flares in the left ventricular outflow tract. Perhaps might be the depth of the implant and even the oversizing, but now has reduced, typically now in the 15–18%. And you can see that through the trial, the incidence of pacemaker decreased. And these patients benefited. You can see an improvement in KCCQ on the Align AR, an improvement on the 6-minute walk test, but you could see that about a quarter of these patients, almost a third of them, did not derive the full benefit, either dead, worse, or no change in their KCCQ. Questioning whether we intervening too late. What we can see at the 2-year data that was presented at the last DCT is that the all-cause mortality continued to increase at 2 years up to 15, but the cardiovascular mortality, which is obviously the one that you can modulate, the one that you can make an impact with the valve intervention, is stabilized. Of course, some of these patients are already on the way down. The ventricle is too dilated. Some of them you might not be able to stabilize, but most of them you are able to then secure some quality of life as well as some improvement and LV remodeling measured by echocardiography. The other device that we have been working on is this J valve, which was by JC Medical, and then they got acquired by Edwards. The design has a unique feature that has these 3 anchors that sit in the sinuses, and then you have a self-expanding valve, which has bovine pericardial leaflets. It's a shorter profile than Jena valve, and the other important thing too is that it has a larger size, 34. Jena valve, you cannot treat anything above 90 as the perimeter, 90 millimeters. And that was another second cause. The most common was the AR felt to be not significant. The second was the annulus was too large. And this valve goes to all the way to 104. And this is under a trial now called Journey that has already initiated and is enrolling patients. And in this early feasibility study that Dr. Garcia presented, which we were core lab and a site as well, 40% of these patients had an annular parameter greater than 90. And despite patients having, 3 of them had right bundle branch block, at baseline, there was no pacemaker. And so that is an important change as well, and because of the anchoring mechanism and the prosthesis design. And these 2 trials are going to also be using cardiac MRI, not only for the identification of these patients. When you're doing the echo and the echo shows that the AR is indeterminate and I'm not so sure, please obtain cardiac MRI. And we're going to be using some thresholds, using also LV dilation greater than 33, or even isolated at greater than 43, and also thresholds of LV dilation according to gender, and MRI at baseline and MRI at 1 year to understand what happens as well with the ventricular remodeling. And both trials will be using MRI. The Journey started. The ARTIST is going to be starting now at the second half of this year. And ultimately, this is a patient of mine that I saw, just to conclude the aortic regurgitation. We are about 20 minutes into it. Then we'll move to tricuspid regurgitation. This was a patient of mine. This is a patient of mine that is a professor at the University of Minnesota. And very intelligent of engineering. He had no symptoms, but he had an echocardiogram, and that was felt to have moderate aortic regurgitation. And he came for a second opinion, and then when he came, knowing that background, I said, let's get a cardiac MRI and prove that you are moderate. And lo and behold, the same story happened here. So the ventricle is already dilated by volumes. You can see the end systolic volume here is not 45 or below, is 49 mLs meter square. By linear dimensions, interestingly, he's not greater than 25. So he's 23. So you got to use the 20 threshold or use volumes. The regurgitant fraction, 34%, so severe with holodiastolic flow reversal. And already impaired strain and some non-ischemic patchy fibrosis with elevated myocardial ECV. So the patient is asymptomatic, but is the ventricle asymptomatic? And that's ultimately what we will be moving for, using new parameters, maybe a combination of remodeling, combination of strain fibrosis, to really identify those that would benefit, obviously even before symptoms. And this is where the field is going to be moving once we establish the safety and the effectiveness of this valve in symptomatic patients. And this recent review that we put together, the state of the art, goes into all these parameters that could be continued to be used for the future. So in closing, significant AR is not uncommon, but terribly underdiagnosed. Remember when tricuspid regurgitation was considered a forgotten valve? And a lot has been happening to really bring the awareness, and by epidemiological studies, it should not be forgotten because it's the most common. So it's actually very common to see tricuspid regurgitation, and we are asking how come we missed this opportunity. We are missing aortic regurgitation, and I would say that 2D echo in some patients is inadequate for quantification of both severity and LV remodeling. We should forget linear dimensions. MRI should be front and center, particularly in these patients with moderate, and even those with severe, that they are asymptomatic, get these other pieces of information. The patients have this very long asymptomatic clinical course. The ventricle is filling, and the guidelines are unfortunately outdated. And as I mentioned at the last slide, while the current goal is to address the need for those inoperable high risk, the success of this journey will be through the transformation of the diagnosis, selection of patients, and treatment for those with aortic regurgitation. So I don't know, Carlos, if we should take a pause here for AR and get some questions, or should we proceed with the tricuspid regurgitation? What do you feel?
I think we should continue. At the end, we'll have some questions.
Okay. So we move to tricuspid, and the right side, it's complicated because it does not operate obviously in isolation. The cable system is connected to other organs. The IVC obviously connects with both liver, kidneys, and the end organs, the body organs. And we need to understand that tricuspid regurgitation is a systemic disease and a problem of both, just like mitral regurgitation, is a problem of forward flow and backward flow. What I mean by that is that we have, in the setting of tricuspid regurgitation, when the pulmonary artery pressure is increased, there is going to be a favoring for this valve to regurgitate and to push back into a lower pressure chamber, right into mean arterial pressure here of 80 millimeters, mean PA pressure. So you make the math, it's going to push back in the presence of that to the lower resistance. After you fix that with a device, here I'm putting a TTVR Evoke device, some of these ventricles are not going to be able to be pushing against this very high afterload. And some of these ventricles might not like it. So it's crucial that we understand not just severity of TR, but also how is this ventricle able to adapt to that. So we need to find better measurements of both forward and backward flow, the consequences of this chronic right ventricular dysfunction or right heart failure, using right heart catheterization, renal and liver congestion, and markers and biomarkers, as well as the health of the RV as a pump as well. And the RV is difficult to be measured, again, by echocardiography. Several things in how you do it, and you can use this multi-parametric approach. Again, the more you ask, the less you get it, and sometimes they are discordant. But because of the shape of the RV, you could use a fractional area change, and that might be one of the best. TOPSY, or tricuspid inner plane systolic excursion, is easy, but you have to be properly aligned. And sometimes TOPSY can be decreased with prior sternotomy or prior aortic surgery or prior cardiothoracic surgery, but yet the radial contractility be preserved, and that's what you capture by fractional area change. Strain might be a better parameter, particularly the free wall strain, but ultimately 3D volumes, if possible, is what we need to do. And this is just showing that why 2D echo is inadequate. The same RV could be considered to be dilated if you come here, or normal in size, depending on how you angulate the probe. So reproducibility, particularly for longitudinal monitoring and studies, is going to be challenging. This has been shown in patients undergoing transcatheter tricuspid valve edge-to-edge repair. TOPSY was not able to discriminate the outcomes. However, RV longitudinal strain was better in separating, and probably because it's reproducibility. So if TOPSY is not good, what if we do the TOPSY divided by the pulmonary systolic pressure? That's the RV to PA coupling. you got two problems here. One is the TAPS is not good. PA pressures estimation also by echo Doppler in the presence of severe TR is also difficult because we tend to underestimate the right atrial pressure. And also the jet momentum between the right ventricle and the right atrium, because of the gap sometimes of the coaptation, is so large that there's not going to be enough momentum, and we tend to underestimate. But nonetheless, what they show was that there was a separation in patients that had a worse RV to PA coupling undergoing edge-to-edge repair. But even better, when you are able to do this by invasive measurement, the C statistics, the calibration is much better. And that goes to show again, is the correlation of the right atrial pressure. When you look at right atrial pressure by echo versus invasive, is all over the place. There is a significant overlap, which we need to do a better job. And that's where the problem is, especially when you go into dealing with massive intervention. So 3D echo, as I mentioned here, can be a better solution. There are software now that allows us to segment this RV and really see and quantify volumes. But it's predicated of obviously you having good 2D echo images so that you can get to the 3D. So if the 2D is bad, the 3D is not going to be any better. And even when we look into recent publications, the feasibility to do 3D echo assessment in experienced centers is not possible in up to 36% of these patients. So in our center, we have moved into actually using a lot more CT, functional CT, as I will show, because the CT can give you that information. A lot of things that I'm going to show to you, as well as cardiac MRI, particularly in the concomitant valve disease. And that's where it provides this three-dimensional aspect. So of course, there is going to be some overlap of what CT and MRI can measure, particularly our right ventricular volumes and function, as well as the anatomical regurgitant orifice area here on the corner on the right. I'm going to show our group has been the first to describe that, comparing with TEE. But also in the cardiac MRI, you can quantify regurgitant volume, regurgitant fraction, and all the annular dimensions that are going to be important for the assessment of the feasibility for not only edge-to-edge repair, but also for TTVR. You got to have a good CT acquisition as well as an MRI. A lot of these patients have atrial fibrillation, and we need to have specific acquisition protocols for that. So that's where we have been devoting the last 3 to 4 years to refining that. A lot of these patients also have chronic kidney disease. So sometimes you might not have a very bright enhancement on the left side, but the right side, which is what you're looking for, can be enhanced. And we typically do this triggering at the pulmonary artery or sometimes during the test bolus. And for patients undergoing transcatheter valve replacement, we do a 60-second delayed acquisition so that we can see the venous caliber passing the IVC, intrahepatic, suprahepatic, and the SVC as well if you're going for heterotopic implants. But here, if you do it properly, you can see the leaflets, you can see the gaps, and you can measure quite a lot, as well as volumes. And volumes by CT, with a properly done CT, have a very strong correlation with volumes by MRI, which is considered to be the gold standard. And you can do this segmentation. And also with the CT, because it's a three-dimensional acquisition, you can do multiplanar reformats, MPR, just like what I'm doing here. I'm moving these crosshairs. And as I move and I pivot this a little bit more anteriorly, you can see the IVC reflux into the IVC. You see the eustachian valve here, and you see a liver that is pulsatile. And that's why, because there's so much regurgitation that this liver moves up to absorb that. So imagine what this will happen chronically. If you do this and you have a good scanner as well, you can see leaflets, and you can measure the leaflet gaps, or you can see two scallops. Tricuspid is called tricuspid, but sometimes you can have 4 leaflets, sometimes you can have 2 leaflets, sometimes you can have 5 leaflets. So there's an incredible variability, and sometimes you can see pacemaker leads as well, and the location of that pacemaker and the interaction with the leaflet is going to be important. And this is a recent state-of-the-art that we did with the PCR focus group, looking at, how the lead, when implanted, could be causing impingement of this lead. Sometimes there is a lot of slack, or sometimes there is fibrosis, And there is what we call a dancing lead. And whenever the leaflet tries to move, the lead goes together again. Perforation laceration, you can see that lead that obviously going through that. Or sometimes it's subvalvular entanglement. So it does not so much touch the valve leaflet, but when it goes into the papillary muscles, it puts some stress and strain into that. And this is important to be recognized, particularly in the consideration for potential lead removal, because you don't want it to bring the lead in with that also papillary muscle or leaflet if you can. So the movement of that lead in the course and trajectory of that lead is something that our group has been looking with the CT as well. More than 35–40% of these patients will have leads. And it is important to respect the tricuspid valve and understand what is the best strategy here. So this patient in the middle, for example, the lead is all the way in the anteroseptal commissure. So septal, posterior, anterior. So 3 leaflets is at the anteroseptal commissure. You can clip here right underneath that. There's going to be some shadowing, but you have to obviously tackle the posteroseptal gap in this patient. In this case here, this lead is completely impinged and has pinned out the septal leaflet. This lead needs to be obviously removed, or you go for a TTVR strategy. And the course and trajectory of this lead is something that also we are examining. Sometimes, if you don't have enough slack, it's too tight, it pulls it up the anteroseptal commissure. But sometimes when you have too much, it's also pushing too much into the posterior leaflet, in the posteroseptal here. So there is almost a sweet spot, and it is hard for us to predict and anticipate that. Then, lots of efforts would need to take place. This is a publication that has come out looking at CID leads, and the bottom line is that patients that have CID-related TR or CID-associated TR, so when the lead is not participating, like in this case is pinning out the septal leaflet, but it's just at the commissure, these patients tend to do worse. So presence of leads typically associate with a more remodeled right ventricle, greater remodeling of the RV, and greater gaps. So you could say, well, let's go leadless. Let's go for a pacemaker that does not have any leads. Well, you could see that leadless pacemakers also can cause trouble depending on who they grasp. In this case here is grasping the papillary muscle, and together with that, the septal leaflet. So now this patient, would try to go for TTVR, but difficult because it might have some interaction with that leadless pacemaker. CT also can help tremendously understanding the IVC, tricuspid annulus location and a relationship. Ideally, when you come from the inferior vena cava, it's important that tricuspid annulus is facing right in front. The more remodeled this right atrium, right ventricle gets, the worse it is, because then you're going to have what we call an offset. And the problem with the offset is that you need to grasp these leaflets very orthogonally. And when you create that offset, you might clip them asymmetrically, and that creates another gap that did not exist. And that is something that we can measure. And sometimes to correct and to come a little bit closer, we might need to come from the left femoral vein. So when we have a greater offset, we typically indicate that to the operator, and you can do that. CT also can show the remodeling if we've done pre and post. This is a patient that had a bicuspid tricuspid valve, and you have 2 clips here, and other experience that we had in the early feasibility study showing that not only the clip reduces TR, it does produce RV reverse remodeling, but it also produces an indirect annuloplasty. So it approximates these leaflets and recreates this more convex shape, saddle shape annulus that was not present before. CT can also provide function and volumes of the RV. And this is an important paper coming from Germany showing that despite procedural success, those that had RVEF less than 45% in red did as bad as those that had patients that had no procedural success. So the procedure success is one part, but the other one is looking at how good is the RV function at the baseline. And you could say, well, but 45% is not so bad for RV dysfunction. Well, that's the case if you don't have tricuspid regurgitation, but if you have tricuspid regurgitation, that RVEF does not tell you, is this forward RVEF or is this backwards RVEF? Remember again, the forward and the backward is just changing volumes. And that's what we need to understand. MRI then becomes a very important piece to be able to tease that out. This is a study from our lab. It's 85–90% of these patients have atrial fibrillation. So you have to use different sequences that allow us to average multiple heartbeats, and also for multiple heartbeats when you do in phase contrast. So this is a patient that has both mitral and tricuspid regurgitation. They are common together. Atrial fibrillation on the MRI, severe dilation. You can see both ischemic as well as non-ischemic fibrosis, patchy RV insertion. That's typically seen with a more remodeled RV and with pulmonary hypertension. And severe tricuspid regurgitation. You had RV stroke volume of 82, but only 45 went through the pulmonary artery. So you do the delta, 37 mLs is what we call tricuspid regurgitation. Oh, but 37 mLs is not severe, it's not 50 mLs. Well, but what is the RV stroke volume? So you have to understand that. So fraction is a much better parameter than just volumes because you index to the RV stroke volume. The other parameter that this group from Spain has been calling is this effective RVF, just like what we talked about. So if you take that forward stroke volume, what went forward, and you divide by the RV and diastolic volume, that is going to be the effective RVEF. And they saw that patients that had an effective RVEF less than 34, in addition to severe TR, tricuspid regurgitation fracture greater than 40%, were the ones that did worse. Small cohort, but a proof of concept. And our group is looking into this with MRI. Here's about 350 patients, understanding TR as a systemic disease. And what we can see when we bracket these patients into three strata of TR severity, less than 20% tricuspid regurgitation fraction, 21 to 40, and then greater than 40, you can see that as tricuspid regurgitation increases, the RV ejection fraction does not change much. However, the forward RVEF obviously decreases because you're accounting for the regurgitant volume. But maybe RV free wall longitudinal strain would be a better parameter because it's starting to pick that up, whereas RVEF does not. And that goes back to the first slide. In addition to that, look at these two patients, one that has mild TR and the other one that has severe TR. Both of them have fairly similar blue myocardium. Septum, 27%, the other one, 26%. However, the liver is very different in these two patients. And what we saw is that as the tricuspid regurgitation increases, the liver, ECV, as a marker of congestion, also increases. So that we might need to be looking not just at above, but also below the diaphragm. Putting all this together, just conclude with a triluminate imaging sub-study. This was a prospective, multicentric, randomized control study that we were part of that as a core lab and as a site as well for part of the triluminate. In patients that were symptomatic severe TR, the eligibility committee felt that these patients we could reduce to a higher likelihood of less than moderate. They were randomized 1:1 to GDMT versus a clip. If not, then it would be single arm. And then we had also the continued access. All comers. We decided that we were not cherry picking. The only ones that we excluded that we thought that was ethically not possible was those that had very decreased renal function, particularly because they were going to be exposed to both CT 3 times at baseline, at 30 days, and at 1 year. So, but MRI was at baseline and 30 days. So only exclusion, low GFR. So this got published in JACC early this year. And what we see is that similar to the main cohort, the 350 patients that were in the New England Journal a couple years before. The patients were the same, high burden of atrial fibrillation. They had leads, they were symptomatic. So 1 out of 5 patients from the main randomized study were part of the imaging sub-study. So we have external validity. Whatever we see it here in the imaging sub-study should be reflective of what we see in the randomized control trial. So what we saw is that CLIP substantially reduces TR. In some patients, it might abolish, whereas the GDMT stabilizes the tricuspid regurgitation. Now that TR is getting worse. In some patients, yes, but most of the time you stabilize with that, whereas the CLIP obviously reduces. You can see this by MRI. This is a patient with a severe TR AFib. We have to use this real time with multiple averaging. At baseline regurgitant volume 98 mLs, 2 clips reduces to 7 mLs, 91 ml reduction, significant reduction, significant RV reverse remodeling. But importantly, you have also improvement of the forward flow because the blood, instead of coming back to the right atrium, now goes into the pulmonary artery. And you decongest this left ventricle. You can see here in diastole, the septum tends to push into the left ventricle, and here the left ventricle can grow again. By CT, that's what you see. Flux into the hepatic veins and IVC, and this is improved RV reverse remodeling. And this remodeling that we see at 30 days by CT continues to be sustained at 12 months, whereas we don't see that happening with a GDMT. And more importantly, we saw in this multicentric study that the amount of RV reverse remodeling, RV and diastolic volume change, is proportional to the amount of TR. So obviously not all patients at the time of the MRI when we did had severe TR. So if you have a regurgitant volume of 22 mLs, you can remodel up to 22, but you cannot remodel by 30 mLs because you can only remodel by the amount that you have. So there is this very strong correlation between the amount of tricuspid volume change, and you can see here patients in blue, the TriClip had a lot more reverse remodeling than patients with the GDMT. And more important, this is one of the last slides here, the more reduction of volume you have, the worse your RV ejection fraction becomes. And why is that? Because I removed the end-diastolic volume. But importantly, you're going to have improvement in the effective. You're shunting the blood instead of to the right atrium into the pulmonary artery, and you have a change in the forward stroke volume as well. And so what? Importantly, patients that have a greater RV reverse remodeling have greater KCCQ change. So when we saw at the first year results presented, it's just a placebo effect because all they felt was just they felt better, KCCQ change. But they are feeling better because you are unloading the RV, you're letting the left ventricle grow, and you're pushing more forward flow. And now at the 2 years, presented at this ACC last month by Saibal Kar on the triluminate, you see now not only KCCQ change improvement, but you see heart failure hospitalization reduction. So the preliminary findings that we saw on the imaging sub-study already were telling these patients are going to do better, and that's why they continue to do better. So in takeaway from this talk, in modern cardiology, you cannot be practiced without a strong multimodality imaging department. You have to have not only strong echo, but I would say strong cardiac CT and MRI. It differentiates your practice and your patient care. The earlier the identification, the earlier the diagnosis, the proper diagnosis, and then the referral to treatment. We need to train more imagers and educate the structural and the general cardiology community. There are several obstacles for MRI access, and we need to break down these barriers. A lot of that could be also by better education. We can do patients with devices. We can do patients with atrial fibrillation, but you need to also modernize the acquisition. And the outcomes will be ultimately dictated by the initiation of the most appropriate treatments. And in tricuspid regurgitation, the evaluation of the RV function, it's inadequate only by 2D echo. It needs to have a complex of the hemodynamics, right heart catheterization, the proper TR quantification, forward and backward stroke volume, and account also for the end organ consequences of this interventricular interaction. Thank you so much.
Wow. 45 minutes, 2 valves. Can you do 45 more to the other 2? Yeah. ¿Alguna pregunta al doctor Joao? I do have one, Joao. So we have talked about coupling in echo, and of course, many of us who have seen it in MRI, how come we don't use it on MRI based on systolic volume, which it seems more appropriate as this is the gold standard for volume quantification. Yeah.
That's a great question. And we just need data. We just had 3D data presented recently by the group from Luigi Badano and Denise Muraro from Italy. We actually have a paper that is under review right now, exactly looking at RVPA coupling by MRI, because we can really separate what's forward stroke volume and what is the end systolic volume. So that is going to be another parameter to be really leveraged. And I think people say, oh, but we don't know what RV is so bad. We don't know how to quantify RV dysfunction, the TR, and the press. I understand that, but sometimes it's because we're not measuring it properly. If we keep trying to get different responses with the same methodology, it's called insanity, right? So we need to have a broader view to understand that it's inadequate. We need to look into other modalities, and that's exactly what you have asked.
Oh, and I have a question regarding that. The systolic volume that you're using is the effective volume or the stroke volume measured by in the ventricle? Basically, are you measuring is the pulmonary aortic flow as a surrogate of the stroke volume, or just the complete stroke volume of the RV?
Yeah, so the ratio for the RVPA coupling would be the forward stroke volume that you measure by phase contrast going through the PA divided by the RV and systolic volume that you measure in the short axis.
I'm going to tell you one thing. We found it to be significant to predict arrhythmias in Epstein anomaly. Also,
there you go.
Let you know.
Yes, it's interesting because you guys have a huge also cohort of patients with congenital heart disease, right? And I gave this talk a few months ago to another adult congenital group, and for the TR, they understood about the liver because, in the Fontan patients with single ventricle, that's what they ultimately die from, right? So it's a Fontan adult liver disease, and we need to understand TRs as a systemic process.
Yeah, I agree. Meaning, for us, we have suffered the Fontan-associated liver disease. We know that increased right-sided pressure is just not good.
Yep.
I think Dr. Forero has a question.
Thank you, Dr. Cavalcante. Should we stay on English or maybe we should
Español, está bien.
Spanish?
Sí.
¿Está bien español?
Sí, más claro.
No, portugués y poco, pero de pronto eso hace que más personas del auditorio se animen a preguntar. ¿Qué tal?
No, te podemos caminar. Sí, no hay problema. Sí.
Bien, gracias. Lo primero es respecto a insuficiencia, regurgitación aórtica. ¿Esa cuantificación la está haciendo con medición directa? ¿Y en qué nivel de la raíz aórtica? Unión sinotubular, creo que le entendí.
Sí, exacto. En la sinotubular junction, porque es lo más reproductivo. Si tentamos hacer un poco más bajo, se va a comprometer porque los leaflets de las cusps de aortic valve están a entrar y todo más. La única diferencia que hacemos algunas veces es el paciente si tiene también un poco de estenosis aórtica, que sea una turbulencia y una aceleración, y ahí algunas veces hacemos abajo en el LV outflow tract. Para hacermos la cuantificación solamente de la regurgitación, de cuánto que está a retornar. ¿Ya?
Bien. Otra pregunta respecto a esto es, ¿quiere decir entonces que debemos utilizar umbrales respecto a la fracción de regurgitación diferentes para eco que para resonancia? O sea, en resonancia 35% ya es severo y en ecocardiografía esperamos a valores más altos.
Sí.
¿Quiere eso decir entonces que es natural que obtengamos valores diferentes por ser técnicas diferentes?
Exactamente. Y esto es no solamente para la regurgitación aórtica, pero tricúspide, mitral y todo más. Los thresholds son específicos de cada modalidad. Si así tentamos extrapolar los mismos thresholds para las otras modalidades, estamos haciendo un problema para los pacientes, ¿no?
Perfecto. Respecto a insuficiencia tricuspidea, en la técnica que utilizan en tomografía, en TAC,
Ujú.
el contraste es puro en las cavidades derechas y es utilizando bolus tracking en la arteria pulmonar para obtenerlo, porque veo que el realce es bien intenso y solo en el lado derecho. Entonces,
Sí, lo que hacemos es una mezcla de 80% contraste, 20% salina. A inyectar, por ejemplo, a 5.5 ml per second por más o menos 22 segundos. Y triggering in the pulmonary artery around 300 Hounsfield units. Si te quieres tener más detalles, te recomiendo es a ver la publicación de Triluminate, porque allá tenemos todos los protocolos con detalles. Este se fue algo que yo quería pasar para la comunidad. He escuchado muchos elogios y muchos agradecimientos, porque todos están a implementar. Mira, ahora conseguimos hacer todo esto. Entonces, a dos métodos, bolus tracking o test bolus, que te puede utilizar y está todo allá detallado, con detalles.
bien, gracias. Y para terminar, una pregunta para nuestro equipo audiovisual. ¿Vamos a tener grabación de la presentación en el canal de YouTube? Porque seguramente van a salir más preguntas después. Ok.
¿O alguien más? No sé si alguien más tenga preguntas.
Gracias, excelente presentación. Nosotros, y aquí está la doctora Dueñas, tenemos un equipo de clínica valvular. ¿Qué experiencia? Obviamente, digamos, sí tenemos la resonancia y creo que se viene utilizando en los casos indeterminados, pero nosotros en la clínica venimos utilizando mucho el nivel de NT-proBNP o BNP como seguimiento. Han hecho análisis, obviamente, en el seguimiento de estos pacientes como adelanto esa disfunción y se asocia con ese riesgo de stroke volume en insuficiencia aórtica, por ejemplo.
Sí, este se podría ser un otro parámetro también para monitorar los NT-proBNP de estos pacientes. La correlación de este con la regurgitant fraction, yo no sé si hay tan bien escrito con esto, pero que se podría ser algo interesante. Lo que vemos en esta publicación que hacemos JAMA Cardiology es que los pacientes que tienen regurgitación aórtica severa, no solamente el NT-proBNP estará muy elevado, pero que también la disfunción de los ventrículos derechos. Esto es algo que vemos más tardíamente. Se da una presentación casi como los stage 4, que si vemos en estenosis aórtica, lo vemos lo mismo. La disfunción de los ventrículos derechos, porque lo contrario de la insuficiencia tricúspide, los ventrículos de izquierdo está tan dilatado que entonces empurra y se causa una disfunción, una carga de volumen para el ventrículo derecho también. No
Creo
sé
que
si te
tenemos...
respondieron la pregunta que estaba a hacer, ¿no?
Sí, muchas gracias, Joao. Muchas gracias. Tenemos una sola última pregunta del público. Creo que tenemos como 2 minutos para responderla. Sería si como la regurgitación aórtica en la insuficiencia tricuspidia, hay un parámetro para definir qué es significativa o severa en la
Sí,
insuficiencia tricuspide. Un umbral.
sí. En aquí en Minneapolis, en nuestro laboratorio, estamos a significante, regurgitación tricúspide significante acima de 35%. Obviamente que es algo continuo, ¿no? O sea, cuando hace la división, obviamente que hacer como binario, pero que es algo continuo. Entonces, 35%, 35 a 40% estamos a lidiar con insuficiencia tricúspide significativa y prognósticamente importante. Y estos son los pacientes que hacemos entonces el report de forward stroke volume dividido por el end RV and systolic volume y toda la cuantificación que te había mostrado antes.
Muchísimas gracias, Joao. Yo creo que siendo así, terminamos y nuevamente muchísimas gracias por por tu presentación y claramente nos ilustraste mucho acerca del uso de la multimodalidad en estas dos valvulopatías. Esperamos tenerte en próximos años aquí presente para que
Ojalá que
realmente
sí, sí. A mí me encantaría mucho. No conozco tampoco Colombia y sería un encanto estar con usted, con vos.
hay que traerte, ya saben, doctor. Hasta luego, Joao. Gracias.
Gracias. Buena semana.